Good afternoon, everybody, and welcome to today's Ask the Expert virtual learning session on integrating mental and public health. My name is Christy Mackey, and I'm ASTHO's Chief Program Officer for Community Health and Prevention. I'm going to be moderating the session today. So to begin, the purpose of today's Ask the Expert session is to highlight research, policy, and practice, as well as public health programs and the intersection of public health and mental health, behavioral health. This platform is an opportunity to invite engaging discussion among the panelists from different disciplines at state and local levels. So we're hoping that you're going to be benefiting from our panelists' different areas of expertise and perspective. ASTHO's been partnering with the CDC's Prevention and Research Center for some time on this project. This virtual event is the second of a three-part series highlighting research and tools developed by the PRCs, as well as the intersection of research and practice. Prevention research centers are a great resource for state agencies across a variety of topics, including mental health and those intersection or integrations. The next virtual learning session that we're going to be having will be at the end of June, and it's going to be focused on rural health. So just to give you a little bit of background, the Prevention Research Center program consists of 26 public health universities or schools of medicine that conduct community-engaged research. Each PRC or Prevention Research Center designs, evaluates, and implements health promotion and disease prevention programs that reduce health disparities. Today we're going to be highlighting research and implementation of mental health programs by Dartmouth University Prevention Research Center and the University of Washington Prevention Research Center. PRCs they generally engage community stakeholders and state health agencies in the implementation of programs. In addition, they offer technical assistance to public health agencies through policy, evaluation, and program development. The goals for today's webinar are going to be to facilitate an engaging discussion between public health professionals and our public health experts. We're going to be identifying strategies for reducing stigma associated with mental and behavioral health. We're going to be looking to gain a better understanding of how public health can better integrate or intersect with mental and behavioral health. And we also want to be able to provide a learning opportunity of how state health departments can partner with their prevention research centers to implement and adapt health programs for people with mental health illnesses. So before we get started, just a little housekeeping. Many of you probably already know this, but the logistics associated with today's virtual learning session. So please log on to both your Adobe platform using the link that's been provided, and you're also going to be calling into the phone number that was provided. So it's both via the computer as well as phone. It's always nice to have everyone engage. If you have questions, please feel free to chat into the chat box. Just go ahead and type it in, and we'll capture your questions or even your comments for the rest of the group to also read during our discussions. Please do, if you have any technical difficulties, go ahead and chat that into the box, and our team at ASTHO will definitely help you navigate through those. So for the good stuff, moving on to our introduction. Today we have Stephen Bartels, who's the director of Dartmouth College Prevention Research Center. We have Julie Kachiver, who's the administrator and state health official for the Nevada Division of Public and Behavioral Health. And we have Leslie Simon, who's the research scientist at the University of Washington Health Promotion and Research Center. So we wanted to give each of our panelists a moment or two to introduce themselves. So, Stephen, why don't you go ahead and start us off with that, please?
Sure, I'll introduce myself. It looks like some people are having a little difficulty getting on, but I'll begin. My name is Steve Bartels. I'm a geriatric psychiatrist, and I am the co-principal investigator for our Prevention Research Center here at Dartmouth. I also run the Centers for Health and Aging here. And for about the past 2 decades, we've been involved in doing research on integrating physical health and mental health, first in primary care, but then more recently, much more of our work has been around bringing health care and prevention to people with mental illness in the community through both self-management and health promotion interventions, and more recently in implementation science. So I'll be talking about that in a few minutes.
Great. Thank you, Dr. Bartels. Before we move on to Julie, just wanted to check in with you. Iwana, are we being able to resolve the issue?
We are contacting ReadyTalk right now, and hopefully they're able to resolve it momentarily.
Okay. So is it that they can't see, or can they not hear?
They're having a difficult time.
They can't hear. They're hearing music, and they're on wait, from what I can see on the chat.
Okay. Okay. So while we're waiting for that to be resolved, why don't we go ahead and have Dr. Kachiver go ahead and introduce yourself, please.
Hello, I'm Julie Kachiver, and I'm the administrator of the Nevada Division of Public and Behavioral Health, and we are a integrated both public health and mental health division here in Nevada, and so we're really joining and really pleased to share some of our lessons learned on what it's been like to try and integrate more closely with physical health, public health, and mental health.
Great. Thanks, Julie. And how about Leslie? Why don't you go ahead and introduce yourself, please?
Hi, everyone. My name is Leslie Steinman. I'm a research scientist at the University of Washington Health Promotion Research Center. We're part of the Department of Health Services and the School of Public Health here in Seattle, Washington. And we're one of the prevention research centers that will be sharing today, and we're really glad to be here. Our work primarily focuses on translating what works in terms of healthy aging and chronic disease prevention and management into everyday practice. So we partner locally and around the state and nationally with public health agencies and other community-based organizations and policymakers to do work in the areas of depression and other mental health issues, brain health, physical activity promotion, cancer screening and prevention, and fall prevention. We also do a lot of work around workplace wellness and engaging adults where they work around health promotion issues. Great to be here.
Great. Thank you so much, Leslie. So before we get started, I need to do a quick check-in. Iwana, do you want to hold off 1 minute to allow everybody to be able to join?
We can hold off 30 seconds. We're trying to talk to ReadyTalk right now.
Okay. In the interim, let's see here. I just wanted to take a quick look. If you are joining the call and you can hear, why don't you let us know what state you're joining the call in from? Got Georgia, Massachusetts, New York, Kentucky, Iowa, North Carolina, Minnesota, South Dakota, California, more Georgia. Yay, Georgia. Massachusetts, lots of Massachusetts. This is, I forgot my glasses today, so you get like a real close up front shot of me while I'm looking at the chat box. All right, so we've got New Hampshire, Montana joining us, and hopefully for those of you who have been able to gain connectivity via the phone, you are joining us at the Integrating Mental and Public Health Ask the Expert session. We've noticed that there is a bit of a delay between calling in and gaining access to the phone, so you can hear what people are saying. So we're just giving it a moment. I want to give me a heads up when we're ready to go.
The ReadyTalk team has contacted the operator-assisted format. However, we're not sure if the issue has been resolved yet, so I think we should go ahead and keep going. It seems like a few people have been able to join the call, so hopefully more will be able to join shortly.
Okay, great. Technology is amazing, but sometimes it can be super frustrating. So just a thank you to our panelists for joining us today. I know you all are extremely busy, but just given the amount of interest and continued discussions around the intersections and interconnectivity between public health and mental health, as well as public health and behavioral health, I'm using those interchangeably for the purposes of today, but lots of interest in this area. So we've, as you know, those who've registered have sent us some questions that they had that they wanted to ask the experts. So we'll go ahead and get started with that. What we've done is we've categorized those questions that have been submitted, and we've created like a guide, so to speak, to kind of help us with our discussion today. Again, if you have questions or comments, certainly go ahead and feel free to type those into the chat box as well. We will certainly respond to them as time allows, but hoping for a pretty robust discussion today. So to begin with, just wanted to start with the subtopic number 1, which is program implementation and adaption. So this is where we're going to be looking towards Leslie and Stephen to answer some questions for us, at least initially. So first of all, let's go ahead and get started with a question. Can you describe how your Prevention Research Center has implemented and adapted public health programs for people with mental health illness? Leslie, why don't you go ahead and get started, and then we'll follow up with Stephen.
Okay, great. So I'm going to be talking through a couple of the slides that folks have access to on their screen, and specifically talking about how our work at the Prevention Research Center has tried to address inequities and access to late life depression care for more vulnerable older adults. So I'm going to tell the birth story of PEARLS, which stands for the Program to Encourage Active, Rewarding Lives. So we know that older adults who are isolated, who are living with multiple chronic conditions, and who may have functional or mobility limitations are more likely to be depressed. And we also know, because of some of those limitations, that they may be less able to seek appropriate care for depression. So in the late 1990s, we were contacted by our local area agency on aging, which is a city and county social service agency for older adults living with limited incomes, and they wanted to work with us to address these disparities. We then developed a model with them based on the chronic care model to try to collaborate with them to develop and test a home-based program for detecting and managing depression among older adults. And the findings from this randomized controlled trial, which were published by Paul Chanowski and colleagues in JAMA in 2004, showed significant improvements in depression and quality of life and a trend towards reduced hospitalizations. So what is PEARLS? I think you can look at it from two perspectives. From many of you joining the call as practitioners and policymakers, it's known as a home-based collaborative care model, or a depression or chronic care management model. So you're actively screening for depression. You're using a measurement-based tool to look at depression over time. We use the PHQ-9. You're training people from existing organizations that access underserved populations to do brief evidence-based psychosocial interventions. You're redefining the role of a specialist in mental health, such as a psychiatrist, to shift tasks to that care manager and then just have the mental health specialist support as needed. And you're doing this work in the home or in the community to address access barriers to care. So for older adults and their families, these are what they say PEARLS is. PEARLS helps me sort out all my stuff. One client says, I really liked how Paul, that's their PEARLS coach or counselor, came to our house to help me figure out how to do the things I used to do and just do them differently. So clients learn problem-solving skills, they get socially, physically active and do more pleasant things, and they get connected to services and support. So a lot of the work I'll be referencing today is the work we've done since then to translate PEARLS from research into practice. So even when you partner with the community from the get-go, there's still a lot of work in figuring out how you make this program work. So on the left side of the slide, you can see the partners I work with, some of them at the local, state, and national level. It's not an exhaustive list. It grows every day, and always looking forward to making new partnerships from webinars like these. This center model is a model we use to translate PEARLs. There's lots of different implementation science frameworks. I think Stephen will be talking about some too. But the idea is that you partner with organizations on the left side of the model. You have some dissemination approach to target organizations like public health departments or social service organizations, and then you examine some of the pieces of how they adopt the program, implement, and sustain it. There's always context at play, which is why it surrounds the model, and there's always learning back and forth between the work we do here at the PRC and what's happening in the community. And on the right-hand side, you can see some of the tools that we've developed from this work. So there's some papers about what we've learned from providers and from clients. There's some articles. I feel like it was a real success to be in the Huffington Post earlier this year as a popular brand, how PEARLs help someone move from depression to dating. And then there's a locator there that the Evidence-Based Leadership Council hosts to help people find evidence-based programs like PEARLs. So I'll stop there.
Great. Thank you so much, Leslie. Dr. Bartels, I'd like to turn it over to you.
Sure. So I'm thrilled to follow my colleague because we started out actually doing some work in integrating mental health and primary care years ago, and we're just thrilled to see it applied to the community through PEARLs, which is just an outstanding example of a wonderful transformation of a model, and now their implementation work is just really terrific. So I think one way to think about what we've been focusing on since that early adventure in integrating mental health into other programs is our efforts to integrate health promotion and health into mental health settings. So it's what we'd call maybe the mirror image, the reverse, but it's also about disparities, and so we also are looking at really vulnerable populations in health disparities. And so if you think about where this all started, it started a number of years ago when it was found in a study of about 5 states across the country that people with mental illness were dying about 25 to 30 years earlier than the rest of the population. And this was really astonishing because the cause of death in the 5th decade of life was not due to suicide, but due to heart disease and cardiovascular disease created by high rates of smoking, high rates of obesity, as well as the effects of medications causing weight gain, and then, terrible access to health care and health promotion and prevention. So what we all know to be our friends here looking at older adults, and we have a Center for Aging here too, the success story has been that we're all looking at enjoying, an increased life expectancy to about 78 years. But for people with mental illness, we're looking at this earlier life expectancy reported in the American Journal of USA Today a number of years ago. And for people with mental illness, instead of the average life expectancy is 53 years, you could say instead of 75 being the new 50, 50 is the new 75. So that's the health disparity that is probably one of the most untalked about but largest health disparities in the nation. 3 to 4% of the population has serious mental illness, and they have an attenuated life expectancy. So due to cardiovascular disease. So this is also an example of something that kind of sprung up in the community. We had colleagues down the street when I was medical director who started this program at Monadnock Family Services in Keene, New Hampshire. Ken Jew noticed that his clients were having early mortality, and he said, gosh, they all seem to be overweight. They have poor access to smoking cessation and a healthy lifestyle, so he developed this idea of InShape, nurse evaluation and consultation, a fitness assessment, individual meetings with a health mentor once a week, free membership at a YMCA or local fitness center, and then individual and group nutrition education and smoking cessation referrals, and then a monthly celebration. Now, we were lucky to see this in the community and then formalize it into an intervention and then do a pilot study where we saw initial benefits. And then we actually had the benefit of doing 2 separate randomized trials. And the first was in Concord, New Hampshire, where we found that people with serious mental illness, about 48% who participated in InShape had clinically significant reduction of cardiovascular risk, either as indicated by a significant weight loss or increased fitness. And then we replicated that in Boston, where about 48% of the population, or about 45% of the population was ethnically diverse, underserved minorities across multiple YMCAs, multiple mental health centers. And instead of 48%, we found 51% had clinically significant reduction in cardiovascular risk. So we are delighted to say this is an evidence-based practice. Not only do we have a randomized trial, we have a replication trial in a completely different setting, different population, distally supervised. And so the problem is, okay, you got the evidence-based practice. As you can see, we published these articles. How the heck do you get people to do it in mental health centers when their job really is mental health, not wellness health? And so that's a transformative kind of culture shift that is happening, but it's not been the mainstream of what mental health has been about for years. So the real question here is what will it take to implement and spread this preventive intervention nationally? And that's what this topic is about, is this issue of how the Prevention Research Centers implemented and adapted it for public health. And what we actually were lucky enough to do was to ask a question and then have it funded by the National Institute of Health and do actually a randomized implementation trial. So the question is, if you want to implement something in mental health organizations where wellness and prevention around cardiovascular risk is not part of the mission, competency, capacity, or funding environment, how do you get it into place, even if it's evidence-based practice? One option is to do a thing called a learning collaborative. Bring together 8 maybe organizations on a monthly basis, on the phone, on a web for 2 hours a week, in a web platform after they've met individually in a kind of boot camp, and then have them post how they're doing on implementing it and share success stories as well as tragedies around how they weren't implementing it. So the question is, does group think and group pressure and group creativity work really well? Or is it better to individually help each organization, because each one is different cultures, different settings, different sizes, rural, urban, and do individual technical assistance? Nobody knows the answer to that question, not just for InShape, but actually for learning collaboratives in anything that has to do with implementation. So this is one of the first randomized trials of the so-called learning collaborative implementation approach. And we basically flipped a coin, and we have 48 mental health organizations across the country that were recruited through the National Council for Behavioral Health Care as our partner, one of the partners also of Leslie's work, implementing it over 3 different phases. We're going to have we have about 2,400 people. We're in about year 3 of this. We've recruited all of the organizations, all of the participants. We don't have results yet, but we are in year 3 to 4. We're in year 4 of the study, and about another year we'll know the answer to this really interesting implementation question. So the kind of span of this process, not unlike our friends at Pearls, started with community identification of need, development of a model in the community, doing an effectiveness pilot study, then 2 randomized trials showing that it's an evidence-based practice, and then moving to implementation research. I didn't tell you about our statewide implementation trial, but we did one in the state. And then we now have this national implementation science study trying to understand how do you implement an evidence-based practice when it's not part of the culture, competency, capacity, or funding of an organization. So that's a long-winded question, but the CDC Prevention Research Center has been really terrific in helping us to empower this and move it forward, along with funding from our friends at the National Institute of Health.
Great. Thanks so much, Dr. Bartels. I do see a number of questions coming in. Perhaps we could take a look at those. And what we're going to do is we have a couple minutes at the end of the Ask the Expert session, so we can go ahead and get to those at that point. The unfortunate job of the facilitator is to keep us on time and keep us moving. So we'll make sure we'll try to address those at the end of the session today. So moving on to subtopic number 2, addressing mental health stigma. This is a good one. I think we're going to go ahead and start with Leslie on this. What are evidence-based approaches to addressing mental health or mental and behavioral health stigma? I think this will be for all of our panelists, but wanted to start with Leslie first.
Sure, yeah, thanks. And full disclosure, this is not an area that I study in depth, but something we come across a lot when we do the work with Pearls and being out in the community and working with social service and other community-based providers to educate about what depression is and isn't and how to best engage older adults who may also have some stigma about what depression is. So there's some recent reviews out about this. Most recently this morning I was looking at one by Growholm from last year, and there are some evidence for doing more short-term impacts of interventions around mass media to reduce stigma, as well as more targeted interventions where you're really targeting those populations who may be experiencing the stigma. And it's not just the folks that are living with mental health issues. It's really a lot of these interventions are for providers that may have some misbeliefs or misconceptions about them. So, for instance, one of the things we often work on is providers thinking that late life depression is normal, that having symptoms of depression is something that's common for folks who are living with a lot of complexities, they have limited incomes, they're isolated, they have functional limitations. And so what we try to do is just do a lot of education as a way to address that stigma. We also try to feature people who are living with depression and other mental health issues to show what that looks like and share that lived experience. And then we also do a lot around behavior change. So what are the skills, what are the attitudes, what are the beliefs that people need to have to be able to understand kind of what mental health is and isn't and reduce some of that stigma.
Great, thanks, Leslie. Dr. Bartels, do you have anything to weigh in on this area?
Yeah, no, I completely agree with Leslie's comments. You know, I think what we've done in InShape, and it's just a little window of and we didn't develop this idea, Ken Ju did, who developed InShape originally, was this idea of thinking about social inclusion when it comes to wellness. So what InShape does is it basically mandates that you do not do health promotion and wellness interventions in the basement of a mental health center on a treadmill. Instead, you give people who have serious mental illness, who are marginalized, who often feel like they're not part of general society, give them a membership to the local YMCA and have it be socially inclusive. So I've literally had conversations with consumers who say, you know, I may not be able to control the voices or the depression, but I can do something about my health. And you know what? I worked out on a treadmill. I'm a member, here's my card, of a YMCA, and I worked out on a treadmill next to the vice president of the bank, and he said hello to me. And so in that way, it's kind of an end around the stigma of serious mental illness to have people be included into the culture of wellness in communities as a co-equal member where they feel empowered and they also feel accepted. Sometimes it took a little work. We originally had some mental health, some YMCAs that said, you can have this room over here to work out. And we said, no. And so we guide that with the health coaches. But I think, again, it's around this issue of social inclusion and giving people opportunities that are just like those that all of us want.
Thank you. And Julie, do you have some comments in this area as well?
I do. I think that in Nevada we have a large growing population of seniors. We also have a really large population of veterans. And behavioral health stigma, particularly related to that, is even worse in the veteran population. And so one of the areas where we've really tried to emphasize is, as Dr. Bartels said, community connection, that it's not enough to just contain symptoms or to provide safety and support for people. That strength comes from greater community connection. And then also really working with primary care physicians so that they better understand suicide, they better understand depression, and the interaction between physical health and mental health, and really working to grow that in our primary care, both physicians, and a lot of primary care is also done by advanced practice nurses here in Nevada. So really trying to grow that better understanding at the community level.
Great, thank you. Again, I'm just looking, there are questions coming up, so I'm hoping our panelists are taking a look at those. Hopefully we'll have some time at the end to answer some of those questions. What we want to do is to keep ourselves on time, move to our next section, and this one is going to be focused on integrating public health and mental and behavioral health. So, Julie, we're going to be looking to you to answer this first question, given that you are a state health official over a super agency, which is public and behavioral health. So what lessons learned, or what are lessons learned and best practices for integrating behavioral and public health?
Well, thanks for the question. We actually have, we've learned a lot of lessons, to be honest. So in Nevada, we took sort of two tacks when we kind of reorganized the Department of Health and Human Services. And one area was to move all of disability services across the lifespan from children, physical, intellectual disabilities, and seniors into a single division that provides lifespan community-based services. And then for mental health, we combined sort of public health and then our direct service mental health services. But we kept children's mental health separate in another division. And so we learned a lot from doing those at the same time. We had some really great lessons that we did learn. There were opportunities. We had better opportunity for integration of physical and mental health, which had been sort of fragmented really before. People are now really talking a lot about how physical health impacts mental health and vice versa. And if anyone has ever not felt well, it's actually really hard to mentally feel well if you don't physically feel well. So while that logically makes sense, it wasn't something we did systemically. We've also really understood, in Nevada in particular, Medicaid is the largest insurer. So of about 2.9 million Nevadans, 657,000 are on Medicaid. And we expanded Medicaid largely to provide that greater access to mental health services. So having a stronger partnership between our public health and our mental health policy and planning and the mental health and physical health policy and planning that was happening at Medicaid really was going to result in stronger outcomes. And that really grew out of a result of when we demonstrated that when you combine public health and mental health policy and planning, we can achieve better outcomes. So if we throw Medicaid in the mix, who's our largest payer source, then we can actually fund a lot of those health outcomes. And really also recognizing, particularly in Nevada, Medicaid had become a really administratively driven agency. It's not very large, even though they're the largest payer. They weren't physically, structurally that very large. And there was a lot of clinical expertise and population health experience in public health, so we had a lot of expertise over here, but all the paying and providing of service or funding of service was happening in Medicaid. And so how can we show that this integration can actually impact a payer source? And changing, when we're talking about population-based health, the opportunity to shape the health of 657,000 Nevadans is a really compelling argument. We had some challenges. One of the things that our structure contains all the public health, all the mental health, and we've actually now included Medicaid's mental health policy co-located in our division, but we also have the direct service. So within our division is also all the state civil and forensic hospitals and our rural clinic system. So we functionally have a large provider of mental health living in the same division. And one of the things that we really had to learn in order to both have good partnerships for growing community-based level services was that we had to draw a pretty strong boundary between all the policy planning and funding on one side and the actual service provision on the other, because what we didn't want was that just because you were the hospital administrator at the state hospital that you got to shape the policy that then all community hospitals had to live by. And so there really is kind of a conflict. We also have the facility regulation in our division, and they regulate the facilities that are in the clinical services type. So we need to make sure that we had a really good boundary. We also found that one of the things we continue to struggle with, as much as we were trying to plan for really good lifespan mental health services on the policy and planning side, having adult mental health over here and children's mental health fragmented in another division was really a problem, particularly for transitional age youth. And what we found with aging and disability services is that they no longer had that problem, because it really didn't matter if you were 17 and a half or 17 3/4, because when you turned 18, you were still going to receive services from the same administrative function. So this, it's my child, it's your child, really didn't happen there anymore because they had integrated across the lifespan. We still see that. We still had a conference call this week about someone who's turning 18 in 2 weeks. and what do we do for 2 weeks until they're 18? And transitional age youth and mental health still continues to be a struggle, largely because of that fragmentation. And so those were kind of a lot of the lessons that we learned, that were we to do it again, I think that our merger with Aging and Disability showed us that direct service really benefits from a lifespan approach, but we really did show positive outcomes from integrating the public health and the mental health policy and planning. And now, as we're trying to integrate Medicaid, that's actually having really good outcomes, too.
Thanks, Julie. I think that's a great example of true population-based health, taking a look at how you integrate all those areas. I want to do this question is I want to pose it to the panelists, but maybe Stephen, you can chime in first. Could you describe the link between behavioral health and chronic disease prevention? I know Julie had mentioned this a little bit about this. The linkage between the two, between your health and your overall mental health status. But Stephen,
Sure.
Do you want to take a stab at it?
Sure. The links are huge, right? I mean, we all know that good physical health or problems in physical health affect mental health and vice versa. So we know from many studies that if, for example, if you have a heart attack and you're depressed, you're more likely to have mortality. If you have cancer and you're depressed, you're more likely to have a lower T-cell count and not be able to fight off your cancer as well. And if you have a hip fracture, you're not likely to rehabilitate, and again, more likely to have mortality. And it goes the other way, too. So these are intrinsically interrelated. And yet, the tragedy is we have to keep on reminding all of us that the head and the body are connected by the neck, that those physicians focusing on the neck down need to think about the mental health status of people and how to take care of that as part of the whole health. And similarly, those of us who are in mental health really do have responsibility for cardiovascular health and risk reduction around physical health. And yet we have to keep on reminding ourselves of that. I like to think that it's kind of an irony that we've been talking about behavioral health organizations that many years ago kind of abdicated health behavior change, or at least people that theoretically had training in changing behaviors said, oh, I don't do health behaviors. I just do those other behaviors. So clearly we have that expertise. We're really well trained in thinking about behavioral modifications or behavioral incentivizing people to change psychological behaviors, CBT, et cetera. But, we should be better at exercising and leveraging our psychological skills in behavioral change towards health behavior change. And similarly, those of us in healthcare should be thinking always about how psychological health directly impacts physical health.
Great, thanks. Julie, do you have any additional information you want to provide in that area as well?
Sure. I would also say one of the things that we look at when we, on the public health side, there are two things in Nevada that are the big killers of people, and it has to do with heart health and lung health. And then we go into our direct service side, and we see there's a lot of management of behavior, which often revolves around cigarette use and food that people want to eat. And people are using things that actually reduce healthy outcomes in order to manage behavior. And getting people to understand that one of the largest complaints we get from people who are in our outpatient services is they don't get enough of their allowance, basically, or their personal allocation to buy enough cigarettes. And so can we have an increase in our allocation to buy cigarettes? And I'm like, oh, please stop doing that. That is not what we want, people using their personal money just to buy more cigarettes. But yet, for direct care providers, cigarettes and junk food help manage behavior. And so trying to get mental health, one, yes, to teach healthy behavior, but to stop reinforcing unhealthy behavior is another big thing that we try to work on, because we can't have one side of us working so hard to prevent tobacco use, diabetes, obesity, while the other side of us is using it as placating to manage behavior.
It's some of those unintended outcomes. So just in mind of keeping us on time, I'm going to go ahead and move into our next area around policy and reimbursement. I think we have some of our panelists have a couple of good examples that they can share with you. So the question is, have there been policies and reimbursement models that have led to successful integration of mental and public health programs? I know, Julie, you'd mentioned a little bit about this through your integration of several different agencies into one. Did you want to add on to that a little more?
Sure. So one of the things that we're really trying to do with this closer integration with Medicaid, well, one thing we did implement were certified community behavioral health centers, which basically require the centers to integrate primary care and behavioral health in a single center, sort of like an FQHC that started from behavioral health and put in some primary care. We also have been working with our FQHCs to also be mental health providers. So a lot of them are both an FQHC and a mental health provider for Medicaid. One of the biggest opportunities that we have found is that while public health gets a lot of grant funding, it's time limited. And Medicaid has a certain service package that isn't time limited, but they have to demonstrate typically that the service that we're going to add to it is going to have a positive health outcome and reduce costs. So can we use our public health grant funding to demonstrate evidence-based practices that then become integrated into our Medicaid state plan and become reimbursable going forward? So sort of using the two agencies to create a sustainability plan for things that we try out in grant dollars. So making one thing we didn't want to do is that oftentimes our grant dollars we would start a really great program, but if there wasn't any commitment of funding after that, it quickly disappeared. So how can we create this sustainability plan while also not using Medicaid dollars and state general funds to try out things that it's really difficult to get things out of the Medicaid state plan once you put them in it. So really trying to maximize our funding by using those strategies.
Thanks. I wonder, just moving forward a little bit, I'm thinking perhaps, Leslie, you could start with this one. How can we ensure that public health programs that address mental health are affordable and reimbursable?
Yeah, that's a great question, and I think part of the reason that it's important to do the community-engaged work that Julie and Stephen have also touched on today at the start is that I think you're planning for sustainability from the beginning. When you're first designing an intervention and then determining who makes the most sense to train in an organization, which organizations to partner with. So, for example, we work primarily with the PEARLS model with community-based social service organizations, which are traditionally outside of the public health and mental health funding sphere. But what we've been able to slowly but surely do is to try to find some more sustainable mechanisms for the program. So, for example, here in Washington State, after we did some work to identify the burden of unrecognized and untreated depression in the population that receives home and community-based services, we were able to get a Medicaid waiver path to cover PEARLS and also the chronic disease self-management program. So every state has a waiver process. It's about every 3 to 5 years you apply, and it's really meant to fill gaps in services that the state feels is important to address. So every state does it a little differently, and this was exciting for health promotion because it didn't just cover evidence-based models, but it also covered providers who could be trained that didn't have a particular credential attached to it. So many reimbursement mechanisms require somebody with both a license and a master's degree, and while that is important for certain interventions, for some of these health promotion models, you really need training and you need supervision. You don't need to have a lot of degrees behind your name. And this is particularly important as we think about training up community health workers and other paraprofessionals that have access to communities that are traditionally underserved and may be experiencing disparities in access to care. I think the other thing I'll comment on that's happening and that I hope to be reporting on in future conversations is right now in this healthcare reform landscape, there's a lot of focus on the value of care and quality of care rather than just care being delivered kind of in quantity. And so we're working very closely with community-based organizations to try to figure out how do they measure how these evidence-based programs are being implemented and what kind of outcomes they're seeing so that they can position themselves to be reimbursed as part of these healthcare dollars that are traditionally going into healthcare settings and not out in the community where people live and work and pray and play. So thinking of prevention, but also thinking of health promotion, right? If I'm living with a chronic disease, if I'm living with a severe mental illness, I spend most of my time out in the community. So thinking about how these organizations can be part of these new reimbursement structures that are coming on play as part of healthcare reform.
That's great. I know we do need to move along, but you did mention community health workers, and I do think that this is an area that so many of our state and local public health partners are trying to, either implement or gain sustainability and certainly scale in this area. And perhaps, I don't know, Julie or Stephen, did you want to touch in any of the areas that you work with community health workers in this space?
Yeah, I'll just make a quick comment, and I completely agree with Leslie. We're learning so much from actually global health and global mental health interventions where places where there aren't any psychologists, psychiatrists, or even physicians, the task shifting to indigenous members of the community who may be public health workers. They may also be peers, and so we're actually doing a lot of work with peers these days, helping to support their interventions using smartphone technologies, but having peers being health coaches, as well as having individuals who may be interested in a health career or maybe just in a transition period of wanting a different type of job, and they don't need a PhD, they don't need an MD to do some of these basic things if we're smart about how we package, train, and support these evidence-based practices. So that really does go towards the workforce issue, that these are surmountable if we're just creative and we get out of our own way and stop worrying about everyone being credentialed with all sorts of degrees. A lot of this stuff can be supervised appropriately by people who are degreed and then shifted on to indigenous people within the community around these coaching interventions. So there are solutions, and that also includes in our area that's rural. I mean, there's no way we could do these sorts of interventions in northern Maine or northern New Hampshire if we weren't, in fact, using peers and using indigenous people within the community to help deliver them.
Definitely agreed. Julie, do you have anything you want to chime in on?
Sure. So we have been also using community health workers, and one of the things that we found, particularly in chronic disease, was that we had to provide them good information to prompt action. And so we've been working on a program called LIFE, our Low Income Health Tracking System, where we get information out of our Medicaid data warehouse that includes both managed care and fee-for-service. And it summarizes it all into a single sheet and then prompts action. So if they haven't had a particular screening, or if they haven't been to a physician, and even if they've bopped around a little bit between different Medicaid insurers or carriers, we can still see it, and that can actually prompt a community health worker to reach out and make a contact, and they actually have all that information based on what services they access. So that has actually been, I think the community health workers feel like to have some built-in targeted interventions, and it's just in the pilot stage now. We started out with chronic disease, and as soon as our mental health and substance abuse program saw it, they were like, can we have that as well? Because then we could prompt action if someone shows up in a hospital or has a potential overdose, and we would be able to then prompt action for follow-up in the same way a failed screening or a lack of screening would. And so I think community health workers are great, and Nevada in particular has over 90,000 square miles of rural areas. So if you want to talk about large, trying to deploy across that, take a look on the map and see how big Nevada is. We can stick Maine and New Hampshire and all of you guys inside of us. So it's really large to try and deploy not a lot of resources out into the rural community. So using telehealth, but also just providing enough information to prompt action. So community health workers have some built-in guidance for this is a way to make a touch with someone. And I have a purpose for calling them other than to say, hey, how are you doing? But I actually have information to drive what that contact is about.
That's great. I want to touch on one other topic before we head into our question and answer area, and I think each of you touched on this a little bit through some of the discussion today, but it would be nice to hear from you really about, you've talked about this, all of you, but just maybe a little bit more detail, a minute or so each. What traditional and non-traditional partners were key in the implementation of mental health programs? And perhaps, Leslie, we could start with you.
Yeah, sure. I mean, I think the key is multi-sectors, multi-levels. I mean, we traditionally started out working with social service providers, and that quickly led to housing associations for folks living with limited income. It led to fire departments who are getting phone calls for older folks who are isolated and don't have emergencies and are looking for someone to talk to. It led to local food banks and nutrition resources. It led to local senior centers offering physical activity programs. So kind of the more you think about how do I reach isolated folks with these evidence-based programs, the more the partnerships expand. And it really expands outside of what we traditionally think of as healthcare or health-promoting organizations. I think we increasingly try to engage policymakers at the local, state, and national level, really thinking about what are more policy supports for this work, not just funding, but also things around training and around supervision and things like that. And I guess the other thing I would talk about in terms of partners is just the importance of having champions and not just one at each organization. You know, we've got amazing people working in this field making this work happen, and the organizations are and working together is what makes the work happen, but at the end of the day, it's made up of people who are doing the work. So just fostering those relationships over time, and it's exciting to be doing some of that even today through these webinars like these.
Great, thanks. Dr. Bartels, do you want to chime in?
Sure, just quickly, completely agree with some of those remarks. Maybe in our health promotion areas, we've developed relationships with directors of YMCAs and dance companies and yoga studios. We've developed relationships with stores that have secondhand or, athletic equipment that they're willing to donate. We developed relationships with state colleges that have physical education students that want to become not just do fitness trainers, but actually work with special populations like this in really cool programs that help people not have early mortality. And we've also developed interesting relationships with peer support organizations and trying to figure out how to partner with those individuals, as well as was mentioned by Leslie, we've done a lot of work also trying to work with our state departments of public health and departments of Medicaid to try to help them to understand why Medicaid should pay for health coaching and these sorts of things in a mental health program, which is a big stretch, but it isn't when you recognize that there's no sense to doing mental health if people are going to die at the age of 50 and you're neglecting their cardiovascular health. So lots of partnerships, and we've learned so much from working with this more diverse community of partners.
Very true. And Julie?
If I could, just add one thing. One of the things that we found is that your partners are really contingent on what community you're in. And so just for an example, we have a program called MOST, which is a law enforcement mental health collaboration to do that line-level intervention when people are getting called on someone who's being disruptive. In the north in Washoe County, Nevada, which is the northern Reno area, that really originated in the police department and the sheriff's department. But in Las Vegas, the police and sheriff really didn't want to engage in that, and it ended up being Las Vegas Fire and Rescue, who was getting called out anyway because they had to call out and stabilize, and they do the EMS. So while we had spent a lot of time and effort trying to engage Las Vegas Metro and Clark County Sheriff, it actually was really wasted because it ended up being Las Vegas Fire and Rescue who ended up being the better partner in that Las Vegas area. So I would just say, one of the things that we learned, and I always tell people healthcare is always local, and so you need to look at who are the natural partners, even if they significantly differ based on what the location is. In some of our rural counties, the local partner are the mining companies. They fund a lot of healthcare. They build senior centers. So while normally we wouldn't necessarily partner with an industry in a rural area, mines have their own doctors and healthcare system, for good or for bad. So that means that they're our partner in that area, which they wouldn't be in Las Vegas, for example. So I would just say, that's one thing, is that your partners don't have to be the same and they don't have to be statewide.
Mm-hmm. Very true. And, we've had quite a few questions that are coming in, I think, that are relating to clearly everything that you are talking about. But one that came in just directly on this topic around partners, perhaps one of you might be able to talk a little bit about the gaps in training that your partners experience while working in the community or with the community. Should I call one of you out? Is there any one of you that?
I can jump in and start. One of the things we've seen is we traditionally had developed an in-person training model for the work we do with Pearls, and while in-person training can be very effective and is something that people really desire, the reality is if you really want to scale an intervention, it can be expensive and hard just to keep that going. The other challenge is we see a lot of turnover in the workforce that we work with, and so that then necessitates there being an ongoing training mechanism. So over the past few years, we've developed and been testing a more master training or train the trainer model, where we are really trying to build regional capacity for training and training within organizations so that they can then train other organizations in their area. That both makes training more accessible, but it also makes the trainer somebody who really gets what's happening in that area, as opposed to somebody who might be coming from a different part of the country, working with a different population, who might not have some of those important kind of contextual understanding. So that's some of the things we've learned.
Great, thanks. Julie or Stephen, do you have anything to chime in that area?
Yeah, I'll just make a quick comment. When you're having people that are, we thought a lot about who should be these coaches. Should we take people that are case managers who work well with people with serious mental illness and then have them get a low-level fitness training certification, because that's pretty easy and straightforward to do? Or do we take people who are fitness trainers and teach them about what mental illness is and why people aren't having trouble with motivation because they're lazy, but they're disorganized, they're depressed, they're on medications that slow them down? Either's okay. And then, or do we take people with lived experience who are peers who actually can talk about their own work around trying to battle both mental illness and physical health conditions like obesity and smoking? I think the answer is all three can work. I think it's about the non-teachable skills. I think we all know who our coaches were that we loved in school, and those who were terrible and didn't know how to coach. And those are often people that can connect and be enthusiastic and empathic at the same time. I think the other things are relatively teachable, but by and large, I think we've gravitated towards, again, case managers who are experienced in working with people with serious mental illness and committed, who happen to be health enthusiasts themselves and are inveterate, joggers and half marathoners or full marathoners on the weekend. They often are some of our best coaches, and also some of our peers that are also very involved in physical activity are among the best. Some of the people that were trained in fitness as their vocation have a little bit more difficulty with the transition. So again, these are all training issues, but they're also kind of perspective issues that we need to work on. Thanks.
I sense the cue from our team at ASTHO for open Q&A, the actual slide here. What I want to do is, because it is 3 o'clock and we still have quite a few questions that our participants want answered, I'm hoping that our team can certainly collect all the questions, and we might be able to share them with our panelists to get some answers out to you all. With that, we're going to conclude for the afternoon. So I wanted to thank the CDC for sponsoring this Ask the Expert virtual event, and really appreciate our panelists for your time and your willingness to share. I think, we talk a lot about mental health and connectedness and community. And so the connectedness piece, I think, rolls over into our ability as professionals to connect with one another, to be able to share the good, the bad, the ugly, so we all can learn from each other. With that, I can't miss the evaluation PowerPoint slide. I'm sure our team would kill me if I forgot to remind you all to please, please, please complete your evaluation. We do apologize for the initial issues at the beginning with the sound, but please, to conclude today, just wanted to remind you that be on the lookout for future Ask the Expert sessions. Our next one is going to be on rural health. And I just wanted to thank Julie, Leslie, and Stephen for your time today. Have a great afternoon, everybody.
Thank you.
Thank you. Take care.
This concludes today's call. Thank you for your participation. You may now disconnect. Today's call. Thank you for your participation. You may now disconnect. Today's call. Thank you for your participation. You may now disconnect. Today's call. Thank you for your participation. You may now disconnect.